So we will move on to the next speaker, Dr. Mohamed Labib from Pursaid, and he will discuss hostile iliac anatomy in EVAR strategies for management.
Thanks, Mr. Chairman. Today, I will run through the hostile iliac anatomy in EVAR. The hostile iliac anatomy in EVAR management strategies. 20% of the patients with AAA have concomitant iliac aneurysmal disease, which have the growth rate of 1 to 4 millimeter per year, with the rupture threshold undefined but commonly more than 5 centimeter. This dilatation makes it unsuitable for adequate distal sealing in EVAR patients. The significant role of the iliac artery during EVAR include an access site for the delivery system, a sealing zone for the stent graft, and a source for the pelvic flow. Therefore, the iliac anatomy is a major consideration during EVAR, and the challenging iliac anatomy remain a big problem for patients underwent EVAR. Chekhov et al. Identify and degrade the factor that modify the outcome of EVAR, and he defined hostile iliac anatomy as follow: short common iliac less than 20 millimeter, iliac aneurysm, external iliac artery diameter less than 7 millimeter, severe iliac angulation, severe iliac tortuosity with an iliac tortuosity index more than 1.6, extensive iliac circumferential calcification or thrombosis more than 50%. This hostile iliac anatomy may lead to hypogastric artery occlusion during the deployment of the iliac extension, and this may have the following complication as buttock claudication, sexual dysfunction, colonic or spinal cord ischemia. A nice paper that assesses the impacts of iliac artery anatomy on the outcome of frustrated and branched endovascular aortic repair. They include 94 patients with hostile iliac anatomy, and they found that hostile iliac anatomy doesn't affect the early outcome of frustrated and branched EVAR, but hostile iliac anatomy procedures are technically more demanding and have a late mortality. Another study which assessed the iliac anatomy and the incidence of the adjunctive maneuver during EVAR, nearly 50% of the included population needed an adjunctive iliac procedure during EVAR, most commonly internal iliac artery embolization. A systematic review and meta-analysis which assess the complication of hypogastric artery embolization shows that nearly 60% of the patients have buttock claudication, and nearly 50% of the patients have sexual dysfunction. Another study which includes more than 400 patients from 124 papers reported ischemic complication nearly in 22% of the all included patients. But they found that these complications were fewer, especially in younger patients versus older ones, women compared with men, and after ligation compared with the only embolization, proximal interruption of hypogastric compared to the distal interruption. And they found that there is no significant difference in complication after bilateral interruption of the hypogastric arteries. The pelvis registry, which assesses the secondary procedures after IBDs, 6 European centers included with nearly 600 patients. They reported complication in the early period following EVAR as a type 1 endoleak, type 1B in 2% of the patients, and in the follow-up in 4% of the patients. The overall redo operations done in 50 patients, which represent nearly 9% of the patients. They conclude that midterm experience with the placement of IBDs is associated with a low incidence of secondary procedure, especially due to type 1 endoleak and occlusion, and the main reason for re-intervention seems to be the short proximal sealing zone, not the iliac anatomy. In 2024, the recommendation of European Society for Vascular Surgery guidelines recommend preserving blood flow to at least one of the hypogastric arteries during open surgical repair or EVAR, and in the patient with internal iliac artery embolization or ligation is necessary, occlusion of the proximal mainstem is recommended. So in this patient, we have two of choices: to preserve the hypogastric in a rescue techniques or occluded. To preserve it, we have a lot of interventions like IBDs, flaring limbs in the form of bell bottom, or parallel or sandwich grafts. For occlusion, we can use coil and cover technique using internal iliac artery embolization or a reversed bell bottom. This is the iliac branched device, and this table shows the iliac branched device instruction for use of the 3 available devices from Cook, Gore, and Jotek. Here in Egypt, we have the Zenith iliac branched device only, with a side arm for the internal iliac cannulation. This diagram shows the steps of iliac branched device deployment, and now I will show one case of our cases with iliac branched device after accurate apposition of the graft, deployment, and through and through wire from the contralateral side. Then introduction of the 12 Frenchies, inside it the 7 Frenchies. Then cannulation of the internal iliac artery and exchange with the floppy wire with a rosin wire, and introduction of the internal iliac graft stent. After that, complete deployment of the iliac branch and the complete deployment of the EVAR, and this is the follow-up after the EVAR procedure. No detected any endoleak and the patency of the hypogastric artery at the left side. Iliac branch device may have some complication like kinks, occlusion, or dissections. After that, the other technique is the bell bottom technique, using an iliac extension in the iliac artery, but with maximum diameter no more than 24 millimeter for a 28 iliac extension limb. This technique is cheap and available, but it has the disadvantage of some anatomical limitation and the long-term durability. The third technique for preservation of hypogastric artery is a sandwich or double barrel technique in the form of 2 parallel stent grafts in the internal and external iliac artery. Also, it is technically easy and available, but it has the drawbacks of the gutters and some anatomical limitation. For occlusion technique, we have a lot of intervention like coil embolization or plug embolization or the reversed bell bottom. We adopt the technique for the bilateral occlusion must be done in staged operations to have the time for collateralization. This one of our cases with coil embolization of hypogastric artery, and this case using syrup plug for occlusion of the hypogastric artery. The last technique is adopted by San Raffaele in Italy, the reversed bell bottom technique, which is indicated if there is no available plug or coil or unfit anatomy. From the contralateral side, they deploy an iliac extension, so the occlusion of the ostium of the internal iliac artery, followed by deployment of the iliac extension and the EVAR. Another hostile anatomy is a tortuous iliac artery, especially of more than 1.6 iliac tortuosity index. They may limit the device delivery. Some of tips that we use is pushing a stiff guide wire to straighten the iliac axis. If it failed, we use a large pull, long and flexible sheath, such as flexor insel sheath from Cook. The last choice is the body flossing technique, using through and through wire after brachial artery access. For management of a small or calcific iliac artery, we can use balloon dilatation and stenting, or using stepwise dilatation by endovascular dilators. The second technique is the endoconduit, which means the paving and the cracking technique, which means the covered stent deployment followed by maximum dilatation without fear of rupture, as it is a covered stent. And the last option is the surgical iliac conduit. So my take-home message for today is elective repair of iliac artery aneurysm if it is more than 4 centimeter or according to AAA diameter. Endovascular repair is the best choice. Preservation of at least one of hypogastrics. If unilateral occlusion, we have to use the proximal occlusion of the main stem. If bilateral occlusion, staged operation is a better. Thank you.